This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. An elderly lady with an hypermature morgagnian cataract, and she also has a pseudoexfoliation, a moderately dilating pupil. And let's understand the challenges in this case. So getting a rhexis is going to be a challenge, as we're going to expect liquid cortex to flow out the moment we puncture. The second reason the rhexis can be challenging is because we might encounter weak zonules, and tearing a capsule in a lax zonule can be tricky. The third would be to deal with the pupil, which is not great, but it seems to be alright now, and just things will get complicated if the pupil comes down in size. And number 4 would be managing the freely mobile nucleus. Now, because of the overlying liquid cortex, I'm not able to assess the density of the nucleus, but invariably in these morgagnian cataracts, the underlying nucleus will be quite dense. So these are the challenges which we're going to deal with it, and let's see how things turn out. So to counter each of these challenges, my strategy would be first to puncture the capsule, let out the fluid, and then using a forceps do a rhexis. And during the rhexis, I would know the health of the zonules and then decide whether to use capsule hooks or to use a CTR. And then for the nucleus management, I would resort to a horizontal chop technique because that would be the best way to deal with a highly mobile nucleus. In this situation, I'm not planning to use any pupil expansion device because the pupil seems to be okay now. And last but not the least, I begin the surgery by making a sclerocorneal tunnel, because in the worst case scenario, if there is a complication and I'm in a situation where I have to extract the nucleus manually, or in the other possibility that I'm forced to use an iris claw lens because I couldn't see the bag, then the extending a sclerocorneal incision is much easier than creating a fresh one. With that idea, I have created this sclerocorneal tunnel incision. As expected, as soon as I puncture the capsule with my bent 26 number needle, there is an egress of the liquefied cortex. So I'm using bimanual I&A to aspirate out all the loose liquefied cortex. This helps me to see things better. So once the visibility improves, the chamber is refilled with OVD and time to perform the rhexis. So as it is customary, I'm going to use my forceps to extend the tear and convert it into rhexis. As I begin tearing, we can clearly see the wrinkling on the anticapsule just beside the edge of the tear. Now this is a classical sign which is indicating that the zonules, at least the anterior zonules, are significantly weak, and we need to be mindful of this. As the rhexis is being performed, the underlying hard nucleus is laid bare, and well, I can assume that it will be a tough nut to crack. So I'm aiming for rhexis which is not less than 5.5 millimeter, and a larger rhexis definitely helps us to manage such difficult nucleus with relative ease. Now, since there was evidence of zonular laxity, especially the anterior zonular laxity, I'm going to introduce the CTR now itself. This is going to provide 360 degrees circumferential strength to the lax capsular bag, and that's the reason I prefer to introduce these CTRs much early. So placing the CTR was relatively easy, and now is the time to deal with the toughest part of the case, that is managing the nucleus. The plan is to do an horizontal chop technique, but since the nucleus is relatively dense, I would like to go and have a firmer grip on the core of the nucleus. For that, my usual plan is to just sculpt a little bit, create a small little central pit. As I'm trenching, I prefer to always stabilize the nucleus with my second instrument. Here I'm using a sharp chopper to stabilize the nucleus as the central pit is being created. And once about 40% depth is achieved, now is the time to perform the horizontal chop technique. The tip is buried into the substance of the nucleus. I'm going to use the longitudinal mode of energy delivery. The tip is buried into the substance of the nucleus. I'm swapping my chopper to a Chang horizontal chopper. The nucleus is just pulled a fraction towards me so that the distal part of the equator is exposed, so that I can go in and hook my equator. This step is critical because the pupil is not very widely dilated. So I need to see the equator as I hook the nucleus with this blunt chopper. So pulling the nucleus towards me exposes the equator, and then I go in and hook the equator of the nucleus, and then the chopper is moved towards the phaco tip, thus ensuring a full thickness through and through crack. The lateral separation maneuvers have to be as gentle as possible because the majority of stress is induced only during these lateral separation maneuvers. The nucleus is rotated, the nucleus is again pulled towards me, the chopper goes down directly opposite to the position of the phaco tip, and then the chopper, which is hooking the equator, moves towards the phaco tip, and a split is created in the nucleus quite effortlessly. The nucleus is again rotated and a final division of the nucleus is got, and we have 3 pieces in the first heminucleus. Dividing the last of the 3 fragments is slightly difficult as there is a small bridge of the posterior plate which is still attached to the other heminucleus. So the one trick is to just tilt up the bridge anteriorly by pushing the nucleus on sideways. This pushes the bridge anteriorly, and then a short burst of phacoemulsification is just going to eat off that part of the posterior plate, and this is a very effortless way of dealing with a very difficult posterior plate. The chamber is refilled with OVD, the nucleus is rotated. Now is the time to tackle the second heminucleus. Similarly, the tip is buried and the horizontal chop maneuver is being done. So as we can notice, there is a tendency of the iris to prolapse out through the side port incision. So at this stage, I'm aware of it. Multiple attempts of lateral separation, especially near the apex of the posterior plate, has to be done to ensure that it is free totally. A bolus of OVD is again re-injected into the antechamber. The free fragment is pulled out of the bag and now is being emulsified in the quadrant removal mode. In this mode again we are going to use the torsional energy. Now subsequent pieces again are being very carefully and very slowly emulsified. Most of the endothelial damage happens during the quadrant removal mode because this is the stage at which the fragments are very much close to the endothelium, and the lens flutter can cause endothelial damage, or sometimes the second instrument, that is the dialer, could rub against endothelium. So these are the steps where we need to be a little bit careful. A time to refill the OVD. The remaining 3 fragments are rotated and brought into the line of action. As I realize, there's 2 pieces are still have some attachment. So the quadrants are maneuvered such that the bridge which is attaching is moved anteriorly. Then using a short burst of phaco, the bridge is taken care of, and now the 2 pieces are free and they are being consumed in a very controlled manner. Now in the presence of the red glow, we can see clearly an area of endothelial damage here. There's a small strip. I think this is the area where the endothelium in that particular region has been stripped off. It is a mechanical damage either with one of the fragments hitting that area or maybe the chopper itself touching this. So I expect some amount of corneal edema in this area. Since there is no significant amount of cortex, time to implant the lens. The chamber is filled with OVD and the planned single-piece hydrophobic lens is implanted into the bag. Side ports are hydrated, and these are the first day pictures. There is significant corneal edema in the area where I was suspecting endothelial touch, and also in the area of the side port and the main incision. And on the third post-op day, the edema significantly decreases, and over a period of time, eventually it clears off well. So a few things to learn from this case. So whenever we see these folds in the anticapsule as we are doing rhexis, that's an indication of anterior zonular laxity. So I would prefer to introduce a CTR earlier in such eyes. The second would be when you're trying to manage a free-floating morgagnian nucleus. The most critical step is to have a good grip. And once you have a good grip, you can always pull the nucleus around towards you, expose the equator, and then place the horizontal chopper. And in a free-floating nucleus, my preferred way of nucleus management would always be a horizontal chop technique, because the forces acting are much more physiological and easier to break the nucleus apart rather than using a vertical chop technique. And because we are working more anteriorly, the chance of endothelial damage is significantly higher. So one need to be conscious of replenishing the OVD frequent enough and try to minimize any endothelial touch as much as possible. So that was it. Thank you for watching and hope you found this helpful.